Hi, this is Shauna Gunaratney, and we will be talking about diagnostics for tuberculosis. So first, when we think about TB diagnostics, it's important to understand what we're trying to diagnose. So we have different diagnostics if we're trying to diagnose TB infection versus TB disease. So TB infection, latent TB infection, we use the tuberculin skin test or the interferon gamma release assays from the blood, otherwise abbreviated as IGRAs. If we're trying to diagnose active TB disease, we use microscopy with AFB stains, culture on liquid and solid media, molecular diagnostics like the NAT, and urine testing, otherwise known as the LAM. So when we're talking about TB diagnostics for latent TB infection, the tuberculin skin test, also called the PPD or the MAN2 test, is used. And so this is when an intradermal injection is performed forming a wheal, and then the person comes back about 48 to 72 hours later, and we read the area of induration, the diameter. This test is only useful for detecting TB infection, not disease, and because it relies on the T cell response, it usually takes about 3 to 10 weeks after the initial infection to turn positive. So this is a slide showing someone introducing the intradermal injection to form the wheal. And then the person comes back, and then you're only reading that area of induration. So you can see surrounding the area of induration, there is a larger zone of erythema. However, it's important that this is not considered to be positive, only the area of induration. So in this person here, the diameter of the induration measures 10 millimeters, which is the measurement that should be used for the test. So what classifies as a positive test depends on what someone's risk factors are for latent TB infection. So if someone has no risk factors for TB, then a test up to 15 millimeters is negative, and 15 millimeters or more of induration is considered positive. However, if someone has epidemiology risk factors for TB, such as coming from a country where there are higher rates of TB, or they have higher other medical conditions that place them at higher risk for TB. We talked about diabetes being one, kidney disease, etc. Then a diameter of 10 millimeters or more is considered positive. And if someone is immunocompromised, such as those living with HIV, or profoundly immunosuppressed on immunosuppressive medications, or have received an organ transplant, then people who have a diameter of 5 millimeters or more are considered positive. So this is not a perfect test. So there can be false negatives. So we talked about recent TB infection. If someone is immunocompromised, they may not be able to respond to the antigen, and the test may be falsely negative, even though they actually do have TB infection. This test is not helpful in young children who have immature immune systems, such as those under 6 months of age. Recent live vaccines can actually cause a false negative test, and then other comorbidities, such as sarcoidosis or protein malnutrition, can also cause a false negative. The other thing about the TST is that it does rely on a human to administer the test and interpret the test. So if there's human error in either of these steps, then that can cause a false negative. In terms of what can cause a false positive, a recent BCG vaccine. So typically a BCG vaccine that has been administered within the past 10 to 15 years can cause a false positive TST. There is a common misconception that a BCG received during childhood will cause the TST to be positive for life. This is typically not true. So if you're seeing someone who's 60 years old getting this test and it's positive, and they received the BCG vaccine as a child at age 2, then that BCG vaccine should not cause the TST to be positive decades later. So we would consider that an actual true positive and not a false positive from the BCG vaccine. Other non-tuberculous mycobacterial infections can cause a false positive TST as well. Then we have the interferon gamma release assay. So there are two commercially available tests in the United States, the QuantiFERON TB Gold or Gold Plus, as well as the T-Spot. So this typically uses whole blood and again detects infection, not disease. And this relies on the T cell response to antigens with a control antigen and TB-specific antigens. So talking about the QuantiFERON Gold and Gold Plus, so you can see the test here. So there is a nil row, which basically is making sure that the T cells are not firing interferon or firing and releasing interferon gamma indiscriminately without a stimulus. Then there is the mitogen row, which is basically a stimulus to try to get the T cells to release interferon gamma. So that way we can measure and make sure that the T cells are responding appropriately and can release interferon gamma. If someone is profoundly immunocompromised, again, living with HIV, on steroids, or a recipient of a transplant, we often see that they are not able to mount a response and release interferon. And so as a result, then this row helps us interpret the test. And so if they cannot release interferon gamma, then the test becomes indeterminate, meaning that it is not helpful in helping us diagnose latent TB infection. Then we have the TB1 and TB2 minus the nil, and again, this is just seeing if the T cells, if they have seen TB in the past, then they will release interferon gamma when exposed to these antigens, and if they do, then that is considered a positive test. The quantiferon gold plus adds that TB2, a second antigen that is thought to be more specific to the CD8 T cell response. This is seen more frequently in people who've been recently exposed to TB and have recently seroconverted or recently acquired the infection. Some of the disadvantages of the interferon gamma release assay, again, it doesn't distinguish between infection and disease. There's limited information in young children. It still can be falsely negative, but more likely indeterminate in people who are immunocompromised. Again, it doesn't pick up recent exposures because it does rely on the T cell response, so it may turn positive up to 10 weeks after infection. It requires proper handling, it's more expensive, and there are a few other species of non-tuberculous mycobacteria, such as M. kansasii, that can cause a positive interferon gamma release assay. So here's a comparison between the TSD and the interferon gamma release assay. In terms of the number of visits, interactions with the BCG vaccine, the interferon gamma release assay has the advantage of improved sensitivity and specificity. You can see greater than 94% sensitivity and greater 97% specificity for diagnosing latent TB infection. The disadvantage, of course, much more expensive. So now moving on to microscopy. So we talked briefly about the fluorescent stain and the Ziehl-Neelsen AFB stain in the section under microbiology. So the fluorescent stain is more sensitive. If you can imagine someone looking under a microscope, it's much easier to pick up something that's fluorescent and glowing among a dark background than sort of the red with the AFB stain in a sea of a blue background. When someone is looking under the microscope and they see cording forms, this is very characteristic of Mycobacterium tuberculosis and a virulence factor like we've mentioned before. This is an example of the serpentine cords that you can see, that you might see under a microscope, pathognomonic and characteristic of Mycobacterium tuberculosis. Some disadvantages of stain as a diagnostic tool from culture: it's actually less sensitive. You need at least 10,000 colony-forming units or organisms per milliliter, and it cannot distinguish between the species of mycobacteria other than if you see the cording that is characteristic of Mycobacterium tuberculosis. So culture becomes the gold standard for diagnosis, and we need to use both solid and liquid media because each has advantages and disadvantages, and so pairing them together helps us give us the most information possible. For non-sterile specimens, for example, if you are running Mycobacterium culture on sputum, these samples need to be decolonized of other bacteria. So here are some of the differences between solid and liquid media. So the most important thing here is that solid and liquid media have different turnaround times in terms of when they can turn positive. So solid media can turn positive in 3 weeks, but can take up to 6 to 8 weeks to turn positive. Liquid media is usually faster. So on average, if there's a sample that is smear positive, meaning there's a higher burden of disease and organisms, on average, it'll turn positive after 10 days. If it's smear negative, lower burden of infection and organisms, it can turn positive on average 20 days. So it's faster than solid media, as you can see. One of the advantages of solid media over liquid media is that you can actually see the colony morphology, so you can see if there are mixed cultures of multiple species of mycobacteria, for example. Moving to molecular diagnostics, or the MTB-NAT. So this is using nucleic acid amplification testing, PCR. The gene expert is typically used globally, and this can detect presence of at least 100 colony-forming units per milliliter. There is a newer test called the Gene Expert Ultra, which has higher sensitivity and a lower limit of detection. It can detect as low as 9 to 15 colony-forming units per milliliter, which, if you remember from the solid media slide, puts it on par with solid media, so nearly as sensitive as culture. So some of the advantages, the turnaround time for the molecular diagnostics are very fast. In about 90 to 100 minutes, it will tell you that it is not just mycobacteria, but Mycobacterium TB. The gene expert, like we said, is more sensitive than the AFB smear because the lower limit of detection is lower than a smear, but higher than a culture, so it's less sensitive than culture. And the molecular diagnostics also gives us an advantage that it tests for a gene with rifampin resistance, so we know within 90 to 100 minutes whether someone has MTB, and if they do have MTB, whether if it's RIF susceptible or RIF resistant, which is very important for a treatment plan. Some of the disadvantages: this test is expensive. It is just detecting molecular material, so it cannot distinguish between live or dead bacteria. So if you're seeing someone during their treatment course, the MTB-NAT may still be positive, and that just may reflect dying bacteria. And so you need culture there to distinguish whether it's viable live bacteria versus dead bacteria. The molecular diagnostics will not give you drug susceptibility testing other than the information about rifampin resistance. So we need the culture to then grow and then be sent off for drug susceptibility testing. This test is also validated only on certain specimens, so it cannot be used everywhere, for example, on blood. So this is just an example of what the Gene Expert machine looks like with the cartridges there. And this is just a schematic of the workflow of how the test works and what the output looks like. And then finally, the urinary lamb. So this is typically used in limited resource settings. Especially, this test is useful for people living with HIV with profound immunosuppression, typically a CD4 count under 100, and especially for those with a CD4 count under 50. So this test can be a point of care test where it's looking at the LAM, or the lipoarabinomannan, that is secreted in the urine by the kidneys, and then it can, if it's found, then that reflects active TB disease in someone living with HIV who's profoundly immunocompromised, and then they can be started on treatment. And those are the diagnostics that we have at our disposal for TB.